Good afternoon, everybody, and welcome to the 48th issue of our COVID-19 series for health professionals by health professionals. I'm Roger Kirby, President of the Royal Society of Medicine, and we're very proud of this series, actually. We've had almost 100,000 people registered to watch it over the 48 episodes that we've had, and equivalent number, more than 100,000 people watch it on YouTube afterwards. And this episode will be available so you might want to rewatch it or pass the message on to your friends. So today we're talking about general practice and the way that it's dealt with the crisis over the last 6 months and more. And I'm very pleased to introduce to you Professor Martin Marshall, who is chair of the Royal College of General Practitioners and a very busy GP in Newham in East London. So Martin, welcome. And let me start off by saying, talk us through the way that general practice has responded to this quite extraordinary pandemic. And starting at the beginning, and then we'll come through this program trying to answer questions from at least some of our registrants. Start at the beginning. How has general practice pivoted to the pandemic?
Yeah, thanks, Roger, and thanks so much for the invitation to join this series and contribute to it. So it's been an interesting experience the last 8 months, it has to say. General practice, possibly more than any other part of the NHS, has changed dramatically as a consequence of COVID and how we've had to respond to it. Starting at the very beginning, I think it's probably fair to say that when COVID hit and we were starting the very earliest preparations, COVID was seen to be principally an issue that needed to be fought in hospitals with very sick patients. There was a recognition that the NHS, at least to a certain extent, needed to continue operating, delivering business as usual. And general practice, which delivers 90% of the patient contacts with the NHS in particular, needed to be protected from the most significant impact of the pandemic, of the infection. So the focus was very strongly on hospitals, on ITU, on really sick patients. I think we quickly realized that you couldn't protect general practice completely because COVID was a community disease and we had a role to play, but general practice was protected to a certain extent in two ways. First of all, by establishing NHS 111 as the first point of access for community questions about COVID, and general practice worked closely with 111 to make sure that that happened. And secondly, by establishing what were called COVID hot hubs. So basically community-based centres where people who needed to be seen beyond the kind of 111 telephone advice or online advice could go in order to get support. And both of those services together, at least initially, protected general practice to allow us to get on with business as usual, which is about managing acute presentations, managing long-term conditions, mental health and physical health conditions, about providing preventative services, about looking after patients in the practice, in their homes, in care homes as well. So that was essentially the way that the issue was framed early on. It's always an interesting challenge because the focus of the media, the focus of politicians has been on what's been happening in hospitals and in particular in ITUs. That particularly was the case when the Prime Minister was admitted to hospital and then to intensive care. In many ways, they're framed as the kind of heroes of the pandemic, and I think that's absolutely right and understandable. General practice has always had a kind of a slightly lower profile, if you like. I don't think that bothers us. I don't think we go into general practice in order to be regarded as national heroes. But actually, some of the things that general practice has done has been heroic in terms of dramatically changing its model very quickly and continuing to serve patients, albeit in a very different way from the way that it served patients in the past. And I'm sure that's going to be an issue that we're going to cover.
Yeah, I would agree that the general practice must be the unsung heroes, and not just GPs, but all your ancillary staff, because I know that you have many people working in your practices. What do you think is the most remarkable change that has occurred in terms of the way you work day to day? I mean, virtual consultations, perhaps, is it?
Yeah, I think that's right. I think that's the most obvious change for everybody. The greater use of technology. So the standard time-honoured model of general practice is 10-minute face-to-face consultations. Prior to the crisis back in January, about 80% of contacts in general practice, 75–80% of contacts in general practice were carried out in face-to-face consultations. At the height of the crisis, that had dropped to just 10%. So dramatic change, and that happened actually over a 2 to 3 week period in March. So to completely change your model of providing care in such a short period of time was an amazing achievement for general practice, and also an amazing recognition by the public that it was necessary, and it was done in order to essentially provide good infection control. That was the reason for it, because we knew that patients coming into general practice, first of all, were exposing themselves to the risk with other patients, for example, of catching the infection. And secondly, we're exposing our staff to the risk of catching infection, which would then have a significant impact on our ability to provide normal services for patients if suddenly a large part of our staff went off sick or had to isolate. So I think it's the use of technology is the main way, and that's happened in a number of ways. First of all, triage. So again, the standard way of accessing general practice used to be to phone up or to go online to make a face-to-face appointment if that's what you thought you needed, and then to get to that appointment a few days, or because of workload crisis, sometimes maybe 2 or 3 weeks afterwards. What happened immediately was that all requests for support or help from general practice had to be triaged. And sometimes that triage was done by clinicians, by doctors or nurses, for example, and sometimes it was done electronically. So I think the use of technology around triage was really important. And then there's a use of technology around the consultation itself. And as I say, we shifted from 75–80% face-to-face to just 10% face-to-face by using technologies. And the most common technology actually was a very well-established one. It was a telephone. It's been around for 150 years. Most consultations took place on the telephone, but a growing number took place on video. So visual as well as auditory connections, and a lot of them took place in text-based ways as well. So I think the greater use of technology was a dramatic change as well. And then perhaps slightly more marginal to that, because of a number of consultations, we started to use technology more in our interaction with hospital services, particularly video and auditory-based outpatient care. So I think there's probably the way in which general practice has embraced technology is the biggest change. General practice has always been very computer literate. One of the earliest practices to go paperless was a practice in Devon, where I used to practice as a partner in general practice. They went paperless in 1974. General practice is almost completely paperless now, so quite different from the hospital sector. But what we hadn't done was to use general practice for technology for clinical interactions, and that's the dramatic change that happened as a consequence of the pandemic.
I was going to come on to ask you a question about booking investigations, but before I do that, let's just go a little bit into video consultations. I think quite a few of our audience would like advice about video consultations. You, as I said, pivoted from in face-to-face to video using Zoom and so on, but without any kind of training. I mean, you just had to learn on the hoof, as it were. And here we are, Gillian Perry Keane sent in a question before this meeting. I see we've already got 13 questions. I should apologize, there's no way I can pose all your questions to Martin, the audience, but I promise you we do file away all the questions, we look at them, and we have at the end of every month a session where usually Simon Wesley and a panel try and address some of the issues. But Gillian Perry Keane says, does the lack of face-to-face consultation lead to more mistakes or slower important diagnoses? I mean, that is a good point, because, and I suppose there are medico-legal issues as well. Just talk a little bit about that, please, Martin.
Yeah, so it's a really important question, isn't it? So let me talk a little bit about how remote consultations have been received, first of all, and then I'll talk about the training needs in order to do them well. So in the earliest days, I think it's probably fair to say that both patients and clinicians embraced remote consultations, and they did so because we knew it was necessary in order to provide good infection control. Patients, I think, some patients liked it more than others. For some patients it was just more convenient. It was easier. For tech-enabled patients, I think it was just great. Other patients who were either less tech-enabled, and I don't think we should stereotype here because there's a lot of older people who are very tech-enabled, but probably more commonly older people, more commonly people who had significant health problems, didn't like remote consultations very much, but nevertheless accepted it. Clinicians in the early days also embraced it. I mean, it was novel, it was quite exciting. We got our teeth into it. We designed it and delivered remote consultations very quickly. So I think in the beginning, most clinicians were content about it as well. Now, I think there's been a shift as the pandemic has moved through, as we've had just a little bit more time to reflect on what it feels like to do remote consultations rather than face-to-face ones. I think we're hearing more from patients who don't like it, who feel that general practice is inaccessible or feel that they don't get a proper hearing, they don't get a proper assessment, who would like to go back to the old ways of consulting, and I guess that's understandable. But we're hearing the same from clinicians as well, who partly miss face-to-face consultations because the nature of general practice is about seeing patients, being with patients, building relationships with them, building relationships over time. That relationship-based care is the essence of general practice. It's our relationships are our intervention in the same way that as a scalpel would be your intervention, Roger. So, I think clinicians too were increasingly concerned. Are they good? Are they bad? I mean, I think the jury is out on that. We've undoubtedly discovered as a consequence of the pandemic that there's far more that we can do remotely in general practice than we thought was possible. So we don't need face-to-face consultations as much as we thought it was necessary. So we're learning that. But what we're also learning is face-to-face consultations are a really important part of building relationships, but also making decent clinical assessments. And I don't think there's any doubt that whilst there are some things which are relatively straightforward, relatively simple, that you can make an assessment without seeing somebody or laying on of hands, using a stethoscope or whatever, there are other problems that we are potentially taking risks by not seeing people face to face. And that's the big decision that needs to be made by clinicians in conjunction with patients. When does face to face add value? When is it necessary? And it might not be for the first consultation, it might be for a subsequent consultation, but that decision, which I think we're learning about all the time about when to use face-to-face is clear. And it's about much more than just being face-to-face in order to be able to examine someone or in order to be able to take a blood test or do an ECG. A lot of face-to-face consulting in general practice is about the soft signs that we use. So it's about seeing a patient who's scared, which you might not pick up on a telephone or on a video. It's about smelling alcohol on their breath. It's about seeing a patient who's dressed in a disheveled way, which is not usual for them. It's those kind of soft signs which are a really important part of our ability as clinicians to be able to make good diagnoses, to be able to help patients, which we think is fundamentally important. As a college, we have embraced technology and supported practices to implement technology, but at the same time push back very hard on those who suggest that general practice could just become a remote medical specialty. And we've got a Secretary of State who's very enthusiastic about technology, and has sometimes, I think it's fair to say, overplayed his hand in terms of his enthusiasm for remote consultations. And we as a college have felt duty bound to push back, which is what we've done. So I think that's kind of where we are in terms of training needs. I think the purpose of the question, I think absolutely spot on. Consulting remotely using technology requires a different skill set to traditional face-to-face consulting. It's a skill set which I think we are learning on the hoof and picking up rapidly. As a college, we provided a number of training resources on our website to help clinicians and indeed to help patients to understand how to make best use of remote consultations. But I think we've got a long way to go as a specialty in understanding how to be effective clinicians when we're conducting remote consultations.
Great. Well, the good question from Jonathan White. Jonathan says, but technology risks increasing health inequalities. How can we address that? Because the elderly, the very poor people, they may not have access. So how do you get around that issue, Martin?
Yeah, I think that is probably one of the most significant concerns. I mean, it does help reduce some health inequalities as well. People who are housebound, for example, who might not be able to come into a premises and might not ask for face-to-face consulting, might have better access. Some people with mental health problems really want to be in the same room, but some don't, so it might improve access. Adolescents, a much underserved group of people in general practice. We see very little in the way of adolescent health problems, but adolescents might be much more willing to consult remotely. So I think we need to get a balance here. There are some ways in which remote consulting is reducing health inequalities, but of course there are many ways, as John said, in which it can be exacerbated. How do we do that? How do we address that as a challenge? I think we need to be cognizant of it. We need to understand the risks. We need to continue to offer a range of different ways of accessing services, including face-to-face approaches. I think that's really important. And probably most importantly, we need to evaluate the impact on inequalities, which is something at the moment I don't think we're doing very well.
Well, we've got 41 questions now, and they're added to the 50.
Would you like my answers to be briefer? I'm sorry, Roger.
No. You're doing great. Peter Cousins says, what guidance have you had about referring patients? And that, I mean, say somebody rings up and have had hematuria or bleeding in the blood in the stool, so on. I mean, how easy is it for you in this COVID era to get those key investigations you need, a CT scan or a colonoscopy or something like that? Are there issues with that?
Yeah, it's been difficult at different times and difficult in different ways in different parts of the country. We refer around about 1 in 10 of the patients that we see. So 9 in 10 we deal with within primary care, that's fine. But 1 in 10 we need to refer for investigations or for specialist advice. In most cases, there have been some cancer services which have continued. Routine outpatient services, by and large, have been shut down, but in most cases during the height of the pandemic, some cancer services were available. We would carry on making 2-week wait referrals for people who we felt needed them. We do know that the number of 2-week wait referrals has dropped dramatically, but that is largely because patients haven't been coming to us with problems. And you asked what the biggest impact is on general practice, and I said technology. Actually, the fact that a lot of patients who would traditionally come to their GP simply haven't come, I think, is also a significant shift. That's changing. Consultations were down by, number of consultations we were doing were down by 24% back in May. They're now back to pretty much where you'd expect them to be, perhaps slightly above where you'd expect them to be in comparison with this time last year. But there was a period where patients weren't coming to see us for a number of reasons. I think partly because they were worried about picking up an infection if they came into a health facility, and partly because they took on board the message that protect the NHS. And I have to say, in retrospect, that wasn't a very helpful message. It was an understandable message at the time. We didn't want to be in a position that we saw in Spain and Italy of patients stuck on corridors rather than being admitted to ITU. But that message, I think, possibly was taken on board too much by patients who didn't then come to see us, so we weren't able to refer them. And at the height of the crisis, cancer referrals were down by 70%. And in fact, the timing is good because today Macmillan have produced a really interesting and useful review of the impact on cancer care as a consequence of COVID. And I think we recognise we've all got a lot of work to do in order to catch up.
Are your colleagues in the college reporting, delayed diagnosis? I know some of my urology colleagues are saying they're seeing people with very large testicular tumours because they've been trying to save the NHS by watching their testicle get bigger and bigger as the teratoma grows, which is very worrying. Have you seen cases like that?
Yeah, we're seeing more pathology that needs more referral as NHS services have started to open up. We collect data within the college through our research surveillance centre that identifies how much time we're spending on clinical administration, which is mostly referrals. And we're currently spending about 30% more time on clinical administration than we were this time last year. So yeah, people have been holding on, and we've been seeing people with more advanced pathology and referring them more rapidly as much as we possibly can to get specialist investigations.
Okay, let's get a bit political. Donna Young was saying that track and trace, they call it NHS track and trace, but some people say it should be called Serco track and trace. So they spent 12 billion on that, our government. I mean, would even a quarter of that, she's saying, would that have been better spent in general practice? What's your view about that?
Yeah, happy to get a bit political. I think there's a general view which I concur with, and we as a college concur with, that established public services, whether they be general practice or in particular our public health function, which is mostly in local authorities, has not been adequately recognised in terms of the contribution that it can make, particularly to track and trace, or test and trace rather, but also possibly until recently, our potential around delivering the COVID vaccine, and maybe we'll come back to that later, Roger. But in terms of test and trace, I think this is more probably public health territory than it is general practice territory. But there's no doubt that the core skill set and the local knowledge and the local connections, the local relationships are held by public health teams, which I have to say have been much decimated over the last decade or more, but it's held by local health teams. And if they'd been given probably a small proportion of the money that has gone into the test and trace system, then possibly we'd be in a better place now. Now, I don't want to be too unkind here, but I think that the test and trace system understands that and is engaging with public health much more than it was in the early days. So we're getting there, but I think it has been slow. And I think I don't know what the reason is, but it feels to me as if the expertise and the infrastructure and the networks and the relationships that exist within the public sector, in my case, particularly in general practice and public health, haven't been as utilised as much as they should have been.
Because we had John Bell on this program, the Regius Professor of Medicine in Oxford, and he was saying that soon we're going to have face-to-face tests with the results back in 20 minutes or so. The saliva test was in the newspapers yesterday, I think. I mean, would that be helpful to you in general practice to be able to give an answer yes or no in a patient?
Yeah, so we've not had the ability to test in general practice. We've had the ability to refer for tests, or at least to say to patients go on online in order to get a test. We've not, until recently, had access to tests ourselves. There's been a pilot which has been run by the Test and Trace programme, which has just completed. And it looks as if we will now have access to a limited number of tests to help us, as you're suggesting, to make proper diagnosis. When we see somebody who has a fever and a cough, we want to know whether they might have COVID or might have something else. So a rapid access COVID test is very helpful there. What we haven't wanted, and this is the challenge for us in many ways, is to be inundated with requests from our patients for tests because they needed it for school or work purposes or whatever. We simply don't have the capacity. General practice is already overly busy. So what we haven't wanted is for general practice to be the solution to a test and trace system that wasn't working properly for the wider community. Now, that was a major concern. It's a slightly less of a concern now because it looks as if the number of tests that are available to people, the availability of tests is improving. So we think it's less of an issue, and we will be welcoming having access to a limited number of tests to allow us to make safe clinical diagnoses.
Okay, well, I'm going to ask you two questions now. I mean, say as a GP in your practice in Newham or your colleagues in the college are faced with somebody who you've got a video consultation, and that patient's saying, I've got a temperature, I've got a dry cough, I've lost my taste and smell, I feel terrible. I mean, how do you decide whether or not patient needs, you've got a bit of a dry cough yourself there, Martin.
Yeah, sorry.
How do you decide whether to refer them to hospital, number one? And then I'm going to lead on then to this issue of long COVID, which I think we're going to see more and more in the news already. It's becoming a major issue. So in the acute scenario, you've got an acute patient, and how do you decide to send them to hospital? I mean, in a sense, it's a kind of life or death decision, isn't it? Because if you say stay at home and they then deteriorate and die, it's going to be your fault.
Yeah.
If you send them to hospital and they don't really need to go to hospital, then that's almost as bad. So what's your reply to that?
Yeah, so let's put this into context. First of all, the vast majority of people that we see in general practice who might have COVID are fit and well and won't have severe COVID. And by and large, with a bit of advice, usually from 111 service, the COVID 111 service, sometimes from us in general practice, will help them to self-care. So that's the vast majority of people. Now, of course, there are some people who are particularly in the shielded group, who are super vulnerable, who we are much more concerned about. There will be people occasionally who will present to us who are acutely sick. And if that's the case, you're right, we have to make a difficult decision. Usually we would, depending on what's available in the locality, we'd refer them to the COVID hot hubs where they would be assessed. They'd have direct access to a COVID test within that hot hub. They'd be assessed, and then a decision will be made about whether they can be looked after at home or whether they need to be admitted to hospital. What we're trying not to do is to get any of those people into EDs, because that's a logjam part of the system, and EDs really can't cope with these problems at a time where they're trying to deliver normal emergency department services in a socially distanced way. So that's kind of the system that we utilise, and it's a very small proportion of people that we see who we have to make the decision about whether to admit them to hospital. Linked to this issue, though, is the issue, which I think is a really sensitive one, and one I don't think we've fully got our head around yet, which is of excess deaths and where those excess deaths are happening. So in a background to normal mortality rates, what we've seen during this crisis is significant excess deaths in hospitals and care homes in the early part of the pandemic. That's what we expected. And then we've seen a gradual increase in number of deaths at home, above and beyond what one would expect. Now, the deaths in hospital and care homes from kind of July onwards until very recently have essentially gone down actually below where you'd expect them to be, whereas the excess deaths at home since probably June, July time have remained high. And the question is, why is that? So are people making an active choice, people perhaps approaching the end of their life anyway, making an active choice that they don't want to die in hospital, they want to die at home? We know that that is a preference, and we know that too many people are dying in hospital who would rather die at home. Is that what it's about? Or is it that people are sitting on potentially significant illnesses, might be COVID, might be heart attacks or strokes or whatever, at home, not seeking help and therefore dying at home? From the data we've got at the moment, not that many people are sitting at home with COVID. Only about 2% of death certificates of people who die at home are related to COVID. The rest are related to other conditions. So most likely it's a combination of patient preference and people dying of other conditions at home. And that's a concern that we need to address and understand better.
Because home visits must be pretty much off the menu, are they? I mean, are you still doing any home visits? And then that leads on to, looking after these people who are dying at home. You'd normally send a palliative care team in there with opiate pumps and so on. I mean, how are you dealing with that particular issue?
Yeah, so I think home visits, particularly visits to care homes, have been down in the same way as consultations within general practice premises have been down as well. I should say that face-to-face consultations within general practice have shot up, I said earlier, shot up to about 45% of all consultations. So that's 450,000 consultations being conducted face-to-face in general practice every day, which is not something you'd believe if you looked at some of the media stories. Home visits and visits to care homes were also reduced, so for the same reason, but when they're necessary, they are provided, and they're provided in by doctors or community nurses in full PPE or whatever PPE is appropriate for the nature. So we're still providing those visits. What we're also doing in order to reduce the number of visits is using monitoring technology more than we have ever done in the past. And some people on this webinar might be familiar with the NHS at Home programme, which is essentially a programme looking at increasing monitoring, particularly of vital signs in people in home situations, either in care homes or at home, who are on the edge of requiring hospital admission. And now we can use pulse, blood pressure, PO2s, whatever, in order to make an assessment about whether somebody is deteriorating and needs to go into hospital or not. So there's a range of ways in which we're able to provide higher quality clinical care without visiting unless it's necessary. But if it is necessary, that's what we're doing.
Okay, we're running a little bit out of time, and I did want to talk about long COVID, but we have actually had a whole session on that. So let's turn a little bit to the stresses and pressures that the medical profession, perhaps particularly GPs, are facing themselves. You know, there have been issues about mental health problems, not just of patients, but of the clinicians, and I suppose of your ancillary staff. And somebody's pointed out the pharmacists are doing a fantastic job of work and all working terribly hard as well. So what are your feelings about that? I mean, are your members reporting stress in response to this pandemic?
Yeah, absolutely. And that's a problem across the whole of the NHS. We know that. Within general practice, we look after a lot of people who are employed in other parts of the NHS, and we're seeing mental health problems, anxiety, depression, in extreme cases, post-traumatic stress disorder in people, particularly who are working in ITU and ambulance services. But across our workforce in primary care, we're also seeing significant problems where people are driving themselves, they're going the extra mile, they're working unbelievable hours, dealing with morbidity and mortality that we've never seen, probably ever, and that is impacting on people. Now, you know, a lot of people, you know, almost certainly wrongly knuckle down and get on with the job, and are damaging their health in ways which are going to be sustained, and that's really worrying. But also, a growing number of people are having to go off sick, and that's got an impact on everybody that's left. And I think, you know, more broadly, this is on the backdrop of a workforce crisis in general practice, which has been building over the last decade, in which we are managing to recruit pretty well in general practice, but we're not managing to retain well. And a growing number of clinicians, particularly middle-aged and older clinicians, are either working part-time, which has an impact on our capacity, or are retiring early. And they're doing so on the basis that they'd rather retire early and have a smaller pension than die in harness. And sometimes it feels like that's the hard decision that's being made. So we have the crisis of COVID on top of an enduring crisis of the workforce in general practice, which we absolutely need to address.
So you guys are not just working the extra mile, you're working the extra marathon, I think. Just briefly, vaccination. Everybody is hoping that the results in November, December from the big trials of vaccines are going to come back positive and show they're safe and effective. So, I mean, that is going to change the situation. Are you going to be able to handle the vast numbers of vaccinations that you're going to have to administer, though?
Yeah, well, that's an ongoing discussion and a very live one at the moment. So general practice delivers the majority of flu vaccinations, has done year on year, has done so extremely successfully. We've got a vaccination rate of somewhere between 70 and 75%, which is amongst the highest in Europe for flu vaccination. So we have an infrastructure, we have systems in place in order to deliver that. And the question is, and that's precisely what we're doing at the moment with a significantly larger flu vaccination program. We've shifted from 17 million up to 30 million people. We're expecting a higher take-up rate. So the question is whether we can use the infrastructure and the experience and the relationships that we have in general practice to deliver the COVID vaccine. At one stage, general practice looked like it was being designed out of the delivery system, because the concern rightly was that general practice wouldn't have the capacity if the COVID vaccine coincided with our need to deliver the flu vaccine. Now it looks less likely that's going to happen. As you say, maybe the COVID vaccine will be available in December. Certainly at scale, it won't be available until January or February, if fingers crossed, if that happens. And the question then is, what role could general practice play? And my feeling is that if general practice is properly resourced, if it's supported with staff, then using our infrastructure, using our expertise, using the confidence that our populations have in us, I think could all deliver a phenomenal COVID program, but it does have to be properly resourced. There's no practices around the country that are sitting around twiddling their thumbs, wondering what to do with themselves. And it's a question of priorities. We all know that if the COVID vaccine works, and if the logistics are there to deliver it, then it could make a significant contribution, possibly not a massive contribution, but a significant contribution to how we deal with the crisis. And general practice is up and ready to contribute to that.
That's an uplifting answer. I'm going to ask you a last question, because I know you've got to get away, which might not be so uplifting in your answer. I mean, Martin, is a second wave coming? Is it going to be worse than the first?
We don't know. I mean, it's looking really bad, isn't it, at the moment? If you just look today at what's happening in France and Germany, and we generally have been 2 to 3 weeks behind France and Germany. We can see all the stats heading in the wrong direction. So I think the second wave, which is what it looks like now, this is more than local outbreaks. The second wave is going to be bad. I don't know whether it's going to be as bad as the first wave. You've had epidemiologists on this who'd be better able to answer that question than we are. Historically, if you look at pandemics, often the second wave is worse than the first wave. We've got to carry on doing everything that we possibly can. And most importantly, as doctors, what we're doing and what we have to do is to support the basic public health measures, the hygiene measures, the hand washing, the face mask, the social distancing, the isolation. That's the stuff that will make the difference. That's our job as health professionals, to carry on promoting those messages and hopefully minimize the impact of the second wave. But I think we're all expecting it to be really tough.
Well, thank you so much. Don't go away, because I just got a few announcements, but thank you so much, Martin. I think that was a really practical session, and I hope that we've given some advice to the almost 1,000 people tuning in and those who are going to be looking at it on YouTube as well. So Martin's mentioned the second wave is coming, and actually we've just had a message from next week's speaker, or at least one of them. We've got Dr. Gary Masterson, who is president of the Intensive Care Society up in Liverpool. And the message we got from him is he's hoping to participate, but it's all hell is breaking loose in the ITU of the Royal Liverpool Hospital where he works. So I think, that's a kind of indicator that things are getting worse. And he'll be talking with Professor Alison Pittard, CBE, recently in the birthday honours, who is a ITU clinician in Leeds. So we're getting some messages from the north of England, and she is Dean of the Faculty of Intensive Care. So do tune in a week today to listen 12:30. One thing I should mention too is you may have heard the excellent Dame Claire Marks in conversation with Simon Wesley last night. On Tuesday night, Parveen Kumar is talking a similar thing, talking about her amazing career for the section of gastroenterology here at the RSM. We're very grateful for all your participation in this webinar, Martin, also for all our attendees. Just remind you, the RSM's under the cosh because we've had to close our building. So if there are any plutocrats watching this program, you might like to make a donation. If you don't want to make a donation, do join the RSM if you're not a member. And if you are a member, come into our building, which is open for meals, and even the Domus is now COVID secure, and you can stay the night there. So thank you so much again, Martin. Thank you for the team that is Maddie and Simon Edmonds, who organize behind the scene all these webinars, and we'll see you next week. Farewell.